Hello everyone and welcome to Your Healthier Choice. I am Dr. Roopnarine and we are coming to you live from our studios at ACTN. On tonight's program, we will be discussing women's health. In studio with me tonight is Dr. Roshni Bissoondatt. Dr. Bissoondatt is a consultant obstetrician and gynecologist. Dr. Bissoondatt is based at the Southern Medical Clinic in San Fernando. As usual tonight, our numbers should come up at the bottom of your screens, and we'll do our very best to answer each and every one of your questions during the program. So guys, let's get the show going. Let's talk about women's health, and let's say welcome to Dr. Roshni Bissoondatt. Roshni, welcome back to Your Health, Your Choice. It's a pleasure to have you tonight.
Hi, Robin. It's great to be back and to the viewers as well.
All right. Thanks a lot, Roshni. So, Roshni, it's been a few months since you were last here, and one or two of your topics and illnesses that I really wanted you to discuss with our viewers tonight at home. I think we should start off tonight by discussing a little bit about polycystic ovaries, okay. or polycystic ovarian syndrome as well, and maybe later on in the program, if we do talk about endometriosis. And in between taking all the questions and comments from the viewers, if we have time, then we could discuss a little bit about fibroid disease in the final segment. All right? Thanks. So, Roshni, let's just start off with the first thing being first. What is polycystic ovaries, and what is the difference between polycystic ovaries and polycystic ovarian syndrome? It seems to me that like a lot of our patients have that complaint, and I think some education on the topic is needed. So could you just explain to our viewers at home what it is and what is the difference between the two?
Okay, so polycystic ovaries just means you have many tiny little cysts on your ovary.
Right.
And this consists of at least 12 tiny cysts. These cysts are 2 to 9 millimeters in diameter.
Right.
So they're very, very tiny.
Right.
But polycystic syndrome, or PCOS as we say, is the symptoms associated with it. So 20% of all women worldwide have polycystic ovaries.
Okay.
But only 10% develop the syndrome.
All right. Is polycystic ovaries or polycystic ovarian syndrome more common in Trinidad and Tobago than in other countries?
Yes, it is.
Okay.
Because it is a genetic syndrome.
Right.
And the genetic distribution would be East Indians and Africans.
Right.
So if you look at worldwide, and in Trinidad, Trinidadians have a lot more.
Okay.
So this is why we have a higher incidence. So I would say we have more than 20% incidence of polycystic ovarian syndrome because of our population.
All right. So, like commonly, patients would ask me, and it's something that people would ask: is other than genetic predisposition, is there something else in our society, for example, the food we eat, or anything like that, which may be contributing to it?
So so polycystic ovarian syndrome, is genetic in the sense it's genetically related to diabetes.
Right.
But it doesn't mean everybody is going to get the polycystic ovarian syndrome.
Right.
So 80% of polycystic ovarian syndrome is actually triggered by weight gain or being overweight.
Okay, so can be triggered by our lifestyle.
It's lifestyle, so it's what we eat.
Okay.
Our lack of exercise.
Okay, that's very important actually.
Yeah, and 20% alone is genetic.
Okay, all right. So if you could just explain to us, so the polycystic ovarian polycystic ovaries is the presence of these cysts on the ovary.
Correct.
Right? Is it only 2 ovaries, or could it
could be on
one or 2?
1 or 2 ovaries.
All right. So can you just give us a little explanation of what is the syndrome then?
Okay. So polycystic ovarian syndrome, like you said, is a diagnosis made with 2 out of 3 criteria.
Right.
One is lack of periods or no periods, and a few women do get 2 periods a month. So this is what we call the irregular periods. The second criteria would be excess testosterone. And excess testosterone means, so you can do it biochemically by doing a blood test, or the manifestations of excess testosterone would be symptoms like acne, excess hair growth, which is in the male distribution. So we're looking at upper lips, chin, around the nipples, from the belly button running downwards and the bikini line.
Okay.
So we're looking at the male distribution, and again, it's linked to the testosterone.
Okay.
Oily facial skin, loss of hair on your head. And then the third criteria is an ultrasound showing that you do have polycystic ovaries. So it's 2 out of the 3 criteria to make the diagnosis.
Right. So we have some slides there. If you want to put them up to.
So, slide.
Just to highlight the differences for the viewers.
So slide 5.
Right.
So as we said, not all women will have everything. You
Right.
can have, and some women, strangely enough, will have the symptoms, which
Yes.
is the excess testosterone,
Yes.
plus the irregular periods, but they don't have polycystic ovaries.
Right.
So remember we said it's 2 out of 3 criteria.
Yes.
So that can still, you can still have polycystic ovarian syndrome
Right.
without having polycystic ovaries.
Right. So you have there being overweight, experiencing a rapid increase in weight, or having difficulty losing weight.
Right. So a misinterpretation is that people feel that the polycystic ovaries is what causes the syndrome, but it isn't. The polycystic ovaries just tells you you're at risk of developing the syndrome.
Okay.
What triggers the syndrome is that being overweight or weight gain. So
Right.
people say, but why would that cause me to get polycystic syndrome? So a better way of explaining it is an increase in your body fat.
Right.
Body fat in women
Yes.
produce excess estrogen. That estrogen is then converted by your ovaries to testosterone.
Okay.
And that's the hormonal imbalance. Too
Right.
much estrogen and then testosterone.
All right. So that's really informative there. So is it that in general that women who are overweight, generally heavy, let's say, yeah, bigger BMI, bigger body mass index, do these women in general have higher testosterone levels?
Yes, they do. They do. They naturally will produce, the body fat
Right.
will produce the excess estrogen.
Right.
And then it's converted to testosterone. So
Right.
yes, they do have. But not all overweight women will have excess testosterone, because
Right.
remember, not everybody has polycystic ovaries and the
Right.
syndrome.
So moving away from this, would heavier women also could be predisposed to irregular menstruation as well, and irregular cycles?
Correct, because again, it's what causes the irregular period is the absence of ovulation, or the egg doesn't come out.
Right.
So remember, period is caused by an egg coming out of your ovary.
Yes.
It doesn't get fertilized.
Yes.
It dies. The
Yes.
hormone levels drop and a period comes down.
Right.
So the reason why you don't have periods is
Yeah.
because the egg does not come out of your ovary,
Right.
and therefore you don't have a period. And this could be anything from 1 month extra
Yeah.
to some people don't even have a period for an entire year.
Right. So I think something that is quite informative or revealing there from what you said is that we need to change a little bit of our thinking, that it's the polycystic ovaries that is making you overweight and having the syndrome.
Correct,
And it's
yes.
really that the poor lifestyle and the lack of exercise based on a person with polycystic ovaries is what gives you the syndrome.
Right.
Am I correct in what I'm
That's
saying
correct. So you have the genetic predisposition to get the syndrome,
there? Right.
but it will come on
Right.
with the weight gain, which is lack of exercise and a poor diet.
All right. So, I mean, you kind of touched on some of these symptoms, right? But this sort of falls in that kind of category of metabolic illnesses and metabolic diseases as well. Can you just explain that a little bit?
Right. So as we said,
Yeah.
it's genetically linked to diabetes, but
Right.
it's not. You are not diabetic.
Right.
So what is the underlying problem? Is
Yeah.
something called insulin resistance.
Right.
So our bodies are producing the insulin,
Right.
but our cells are not responding to the insulin,
Right.
and this is called insulin resistance.
All right.
And insulin is needed to break down glucose. So
Right.
if you eat and you absorb glucose and your
Yeah.
insulin isn't working,
Yeah.
then you don't break down your glucose. You
Right.
then store it as fat.
Right.
So that's the knock-on effect.
Right.
You weight gain causes the insulin resistance, and then the insulin resistance makes you put on more weight.
Right.
And then it's even more difficult to lose the weight.
And just to take you back, are you saying that 20% of our women in general in Trinidad and Tobago has polycystic ovarian syndrome?
20% of all women worldwide will have polycystic ovarian syndrome.
That's a high amount.
It's a high amount.
And in Trinidad, it's probably more.
It's more because of
our
our
lifestyle.
population and our
Right.
lifestyle.
Right.
And if you realize,
So then it really is a big problem.
it is because if you
really
look at,
it's a big problem in Trinidad.
and if you look at kids now,
Yeah.
they are a lot bigger or heavier than
Yes.
kids 20 or 30
Of
years
course.
ago.
Because of lifestyle.
It's because of the lifestyle, you know.
So they're more at risk of developing polycystic ovarian syndrome.
This is why people talk about it more now, because we are heavier, we eat badly, we have so much takeouts, and you know, if you talk to people, you will hear them from Thursday, Friday, Saturdays, pizza, Chinese, KFC, you know.
But what's great about what you're pushing out there is that you're not just telling people, I mean, doctors, sometimes we just tell people, do this, lose weight, do that. But what you're really giving us is the rationale why.
Why? You don't
the importance
understand.
of women not getting heavy. You're actually explaining to the viewers why they need to avoid getting heavy, because that's the problem that we face in Trinidad.
Right.
Now, the big question as well is that, I mean, plenty of our patients and so on might say, Robin, could this become cancerous? Could this cyst be cancerous? What is the answer to that?
No.
Because that's a worry, you know, somebody sees a cyst, a younger person, no.
No.
Right.
So polycystic ovaries is only one type of ovarian cyst.
Right.
And although they have many tiny little ones,
It's one type.
One type.
Right.
And polycystic ovaries, first of all, it doesn't become cancerous.
Right.
And also they don't get bigger. So a lot of people come saying they have a lot of pain and they know they have polycystic ovaries, so they feel the cyst is getting bigger.
Right.
But polycystic ovaries remain 2 to 9 millimeters.
Okay.
If you have a bigger cyst, that is a different category of a cyst.
All right. Can you have other cysts with polycystic ovaries as well?
Correct. And the most common thing is an ovulation cyst,
Right.
which we call a corpus luteum. So women get that every month when they're ovulating.
Right.
And those are between 2 to 5 centimeters.
All right.
And then the other type of cysts would be things like dermoids, cysadenomas, but those are different.
All right.
And you can have both.
All right. So Roshni, I have a few patients. They come into me. They're a little bit heavier. They have polycystic ovarian syndrome, right? They might have facial hair in the male distribution, and have a little bit of hair loss. What can we do to help these patients?
Right. So in the category.
Or what can they do to help themselves?
Right. So the category where it's weight gain.
Yeah.
You have to lose the weight. There is no other way to fix the polycystic syndrome.
Right.
So it's not weight, it's the body fat that you have to lose.
Right.
Diet and exercise.
It's more like a percentage fat.
Correct.
Right.
So it's diet and exercise.
Right.
And what we have to stress to women is that it's not a quick fix.
Right.
It will take you months to lose weight.
All right. So Roshni, what if one of somebody walks in here right now and says, well, Roshni, it's really hard for me to lose weight because I have the polycystic ovarian syndrome, and that's why it's harder for me to lose weight. Is that an accurate statement or not?
That is true.
It is
because
true?
of the insulin resistance,
Okay.
it makes you put on weight, and again, your metabolism slows down.
All right.
So you have to do more to
Right.
lose weight,
Okay.
or to kickstart your metabolism.
Okay. So we're gonna give our viewers some real practical advice, right? So you're saying the first line treatment of this thing is to lose weight, lose fat,
Correct.
lose fat, right? Maybe a little bit out to your field, but telling somebody to go and exercise is really sometimes kind of confusing, right? Because people want bang for their buck. You know, if you're going out there to do a half an hour of some sort of activity, you want to make sure that it's really focused and that you're getting your bang for your buck. What would you recommend? What type of exercise would you recommend for patients with polycystic ovaries to really achieve their goals quickly? Or achieve their goals. It's a little bit out of your field,
Right.
but I'm sure it's something that you come across.
Yes, so it's, again, you can't achieve that goal quickly.
Well, achieve their goal.
Yeah, so it is the diet and the exercise. And I always tell women,
No, but my question is, what's the best type of exercise?
so it's the more aerobic or cardio exercises.
All right.
So it's a long time, lighter reps. So
Okay.
more light. Because a lot of people go to the gyms and they do a lot of weight training. So weight training and muscle building, it burns fat.
Exactly.
But it also builds muscle under the fat.
Right.
So you still have the fat.
Right.
So it's more the cardio type of exercises. So you're walking, you're running, your treadmill, your cross trainers. Do a little more of that as opposed to heavy weight training.
Okay.
Yeah.
And I suppose is the routine half an hour
At
every day?
least, yes, half an hour to 45 minutes, at least 3 to 4 times a week.
Right.
And I always tell patients as well, don't get frustrated. Don't think in your mind, I have to do 30 minutes today. When you start with 10 minutes your first day.
Right.
Or the first week.
Right.
The second week, go on to 12 minutes.
Right.
The third week, 15 minutes.
All right.
You gradually build it up to get accustomed.
So let's say our patient does that and they're pushing the aerobic activity and they're losing weight, right? What happens when they begin to lose the weight? Is it that if the facial hair reduces? Is it that the fertility improves? Is it that what happens exactly?
Right.
Because
so
we're saying exercise helps you to treat this syndrome. So what happens to them when they start exercising?
Right. So all of the symptoms disappear except the hair growth. So
Okay, so all the symptoms such
as acne,
right,
oily facial skin,
right,
loss of hair on your head.
that will disappear.
Those will improve and get better.
Okay.
But hair, once it's grown, it's literally grown for life.
So this is hair, what are you talking about, on the face?
Facial hair, around the nipples, from the bikini line.
So so that's moving away a little bit. What are the best treatments for that type of hair? I mean, women will know, but just spell it out for us, us men who might be listening on.
So people wax, they shave, they bleach, but the only permanent hair loss is really laser.
Laser.
Hair laser.
Okay. And when women do the laser, is it that the hair is not going to grow back again in the future?
Right. So the difference is if you treat polycystic syndrome, you prevent new hair growth. Right. So let's just say you have 10 hairs.
Right.
So treating the polycystic syndrome, you'll remain with 10, and you laser it, the 10 goes away.
Right.
But if you don't treat the syndrome and you laser, you'll get the 10, but more will keep coming up.
Right.
So you laser off the 10 and 5 comes up.
Right.
So you have to treat the syndrome to really stop the hair growth.
All right. So we have our patients, they're exercising, they're losing weight, they're doing the laser for the hair on the face. What other treatments can we offer them to help them with this syndrome? Is there anything else we can do for them?
Right. So, I mean, topical things for acne.
Of course.
Right?
Yeah.
So I don't know if you're looking into the long-term complications of polycystic syndrome.
If you go through that and how to treat it.
Right. So we spoke about symptoms. So there are more long-term complications.
Right.
So, and number one is infertility or difficulty getting pregnant.
Right.
So, and the reason for this is normally a woman should have 12 to 14 periods per year.
Right.
If you have polycystic syndrome, you might only have 3 to 4 per year.
Right.
So which means only 3 or 4 eggs are coming out.
Right.
So it takes much longer to get pregnant.
All right. So women with polycystic ovarian syndrome, it's a little bit more difficult to get pregnant.
Correct.
But you can still get pregnant.
You can get pregnant.
I think that's a little bit of a misinterpretation in the community.
Yes, you can get pregnant and you will, especially if you treat the syndrome. That goes away, and your periods come back.
All right. How about women who just have polycystic ovaries? Is it more difficult for them to get pregnant as well? No.
There's no increased risk of infertility.
Right.
So if you don't have the syndrome, you are like anyone else, you can get pregnant as normal.
All right. So, Roshni, I think at this time we'll take a little break.
Okay.
And when we come back, we'll just continue on a little bit with the polycystic ovaries, and then we'll take it from there. All right?
Okay.
All right, guys, so we're going to take a little break, and Dr. Bissoondatt is going to gather her thoughts. And I would just like to formally invite you to send in your questions to us, and we'll address it during the program. All right, guys, so we're just taking a short break.
ACT and The Voice launches a new and versatile culinary series called Stacy's Kitchen.
Hi everyone, welcome to Stacy's Kitchen. And on today's episode of Stacy's Kitchen, we will be cooking up a Thanksgiving feast. Our rolls are ready and looking yummy. Nothing like a good curry chicken and some basmati rice. So I'm gonna start putting my wings in to fry.
We will showcase how to make tasty international cuisine with our local products. We emphasize meals on a budget with our selected ingredients.
Restez à l'écoute, Stacy's Cuisine. Au revoir.
So you can put how much, depends on how big you want it. So our fish is ready. Oh my God, look at that. Oh my God, oh my God. Just like paratha, this is lovely.
Join us on ACTN on Monday evenings at 6:30 p.m. Don't miss Stacy's Kitchen, exclusively on ACTN The Voice.
All right, guys, welcome back. My name is Dr. Roopnarine. I'm here today with Dr. Roshni Bissoondatt. We're having a discussion on women's health, and currently we're talking about polycystic ovarian syndrome. So Roshni, before we went off to the break there, you're going to tell us about the long-term complications of polycystic ovarian syndrome. If you could continue on with that, please. Sorry.
Okay. If you could just bring up slide 10.
Slide 10. Yeah, slide 10 there, Josh.
So there are three main long-term complications. As we spoke about, difficulty getting pregnant or infertility. Correct.
Yeah.
The second would be the risk of developing true diabetes.
Right.
Because insulin resistance, if you don't treat it, will turn to diabetes.
Right.
And then the risk of cancers of the lining of your womb, which is called endometrial cancer.
Right.
Right, so we went into the explanation for the infertility because that
Right.
basically is a skipping of the periods and the eggs aren't coming out frequently.
Right. So let's hear a bit about the other two.
Right, so developing diabetes. So if you have insulin resistance for many years, you will develop diabetes because you're not treating it. That insulin resistance then turns to diabetes. Right, and I'm actually seeing lots of women in their 30s who weren't treated, and they all have diabetes at this stage in their 30s.
That they weren't treated.
They weren't treated for the polycystic syndrome.
Right.
They knew they had it in their teens and early 20s,
Right.
but it wasn't treated.
Right.
So we spoke about the weight loss.
Right.
But you see, what a lot of women go on is the contraceptive pill.
Right.
And one thing to note is the contraceptive pill doesn't treat polycystic syndrome at all.
Okay.
All it does, it gives you regular periods. So you're fooled into thinking you're treated.
Right.
And then it also, many of the new generation pills have anti-testosterone properties.
Right.
So it suppresses the testosterone while you take it.
Right.
So your symptoms get better. So
Right.
the acne, excess hair growth, oily facial skin
Right.
on the periods.
Right.
So they're on it for 10 years,
Right.
thinking they're cured, but they're
Right.
not. You still have the underlying problem of the polycystic syndrome.
Okay.
So when they come off the pill, when they're ready to get pregnant,
Everything blows up.
everything flares up.
Right.
And now they're thinking it's the pill that caused them
Right.
to not have the periods again.
Right. That's very
yeah.
insightful information there,
Yeah,
actually.
yeah.
That's very insightful. So the so what? Sorry, I interrupted you there. What is the treatment for the long-term insulin resistance? Is that why we put people on metformin?
Right. So the metformin is a second-line treatment for treatment for polycystic syndrome. So
Right.
first line is always, as we said,
So what is the
diet and
purpose of the
exercise.
metformin?
Metformin helps with insulin resistance. So it sensitizes your natural body cells to your insulin.
Right.
So it is a treatment form for polycystic ovarian syndrome.
Right.
So it in itself, it lowers that insulin resistance.
Right. So the key thing you're pushing back out to the viewers there is that even though they might not be diabetic,
Correct.
because everyone associates who actually watch this program with my previous host as well would all know about metformin and all know about the role of metformin in treating diabetics, right? But what you are saying is that in this category of persons and the category of women, that we use the metformin even though they're not diabetic to reduce the insulin resistance and therefore reduce their symptoms.
The symptoms, and it also, so one good side effect is it helps you, there's a loss of appetite.
Right.
So you do actually eat less, and it helps with the weight loss.
Yeah, that's a common loss, lack of appetite, true, but a lot of people really find it difficult to tolerate metformin.
Right, the side effects.
The side effects.
Nausea, vomiting,
Exactly.
tummy cramps, diarrhea.
Just really specifically, what dose of metformin would you recommend to these patients? One a day, one tablet 3 times a day? How would you recommend
No, so
it?
the correct dose is
Yeah.
actually 3 times a day.
One tablet 3 times
3 times a day. But if you go onto that 3 times a day, trust me, by that first day you'd stop it.
Exactly, that's why I brought it up.
So no, I wouldn't start it like that. I would
Right.
start at 1.
For a while,
For a while.
tolerance.
Yeah, 2 weeks, 3 weeks.
Yeah.
Then you go up to the 2.
Yeah.
Next 2, 3 weeks,
Yeah.
however long you want before. And then you could go up to 3. But if you don't think you could ever get up to the 3,
Yeah.
stay on a dose that you're comfortable with, because
Yeah.
a little something is better than nothing.
Okay. All right. So therefore, that's the second part of the equation, the insulin resistance. The third part of the equation is the third risk. You said there was cancer. Of the
Lining of your womb.
All right.
So that's
Explain that one
called-
first there a little bit.
Right. So remember, a woman's
There you go there. Yeah. It's on the screen.
a woman's lining is supposed to shed every month with
Right.
the period.
Right.
But if you don't have a period, there are 2 spectrums to polycystic syndrome. Those who have a very, very thin lining, so they have no periods. And then the
Right.
other spectrum is those that have a thick lining.
Right.
Because the period isn't coming,
Yeah.
it's building up and building up and building up.
Right.
And it's not shedding. And when it stays there for months, and a lot of women skip 3 to 6 months, it can become cancerous.
Right.
So to prevent that, we always get women to bring down their period artificially.
Right.
If once you cross 3 months of no period,
Yeah.
you must bring it down because of that risk of cancer of the lining of your womb.
Okay, that's that also is very informative. I think a lot of our viewers are getting valuable information tonight. So, what other treatments are there for polycystic ovarian syndrome?
So the syndrome itself, there are really no other
Well, we went
treatments.
through.
Yes.
How about for the polycystic ovaries itself? Is there any treatment for it?
No.
Okay.
So sometimes polycystic ovaries develop at adolescence.
Right.
And sometimes it will stay there for the rest of your life, but you
Right.
never develop the syndrome.
Right.
You just have polycystic ovaries. But other women,
Yeah.
you do see it. You do an ultrasound, you scan them, and you see like 20 cysts.
Yeah.
They lose the weight, they lose the syndrome, and they come back, and you see 5.
Okay.
So and you see, what patients need to understand is seeing the polycystic ovaries doesn't mean that you have the syndrome, or it's used to kind of look at your symptoms then.
Right.
It's really based on the skipping of the periods. Because
Right.
the cysts are only to diagnose.
Right.
Not to monitor your progress.
Okay.
So you don't need to do an ultrasound every 3 to 6 months
You do
to
not.
check
It's
to
never-
check your
nothing's
ovaries.
gonna be happening.
No, because you could
Yeah.
have it for your whole life.
Yeah.
But don't have the syndrome.
Right. That's big question out there for those patients at home who might be having difficulty getting pregnant, right? Could be quite a really difficult time for them. What is there any special treatment for those women who might be having difficulty with fertility? What can they do? Is there any treatments, medications, anything that they
Yes.
could use?
Yes.
Can you address that for that crowd out there who might be difficult conceiving?
So again, there is medication for it.
Right.
So there are two on the market right now. There's
Right.
clomiphene and there's Femara.
Right.
So it helps with is for the eggs to develop.
Right.
But it doesn't mean that the egg will come out of your ovaries. So some women
Yeah.
don't develop eggs at all.
Right.
So these medications help the eggs to mature.
Okay.
And then you may need a second medication, which is called HCG,
Yes.
to help the egg to come out, because
Right.
with polycystic ovarian syndrome, the ovarian capsule becomes very thick.
Right.
So sometimes the egg doesn't come out. So these medications help your egg to come out.
Right.
But what women also need to understand is the higher your BMI,
Yes.
you're less chance of it working as well.
Okay.
So in conjunction with using the medication,
Yeah.
diet and exercise helps the medication to work a lot better.
Right. And if fertility would improve.
And the
with it.
fertility will improve and you will get pregnant.
Okay.
Now, that is your first line.
Right.
Now, you don't only just give the medication. Sometimes you have to do what is called follicle tracking.
Right.
So you have to do an ultrasound monthly to see if the egg is actually developing and to get the correct dose. Because it's not just one dose. You can actually double it and triple it.
Right.
But you don't just go on to the highest dose because there are serious side effects.
Right.
And that's something called ovarian hyperstimulation syndrome. And it's a serious syndrome because you
Okay.
get leaking of fluid into your body
Right.
spaces.
Right. And we don't want that.
You don't want that. You get fluid in your lungs,
No, no.
fluid in your tummy.
Yeah.
So,
So it has to be something very carefully titrated
Carefully monitored.
and monitored with
Correct.
the obstetrician.
yes,
That's good information because give people hope.
yes.
Because I have a lot of people who think once they have polycystic ovaries, ovarian syndrome, and they can't get pregnant, and that's it. You know what I mean?
Correct,
But
yeah.
at least you give them some information that, listen, there is hope, and there's a whole medical treatment for it.
There's also surgical.
There's also surgical treatment.
So
Tell us.
a lot of people don't understand that seeing the cyst doesn't mean that you can't get pregnant, first of all.
See this, right?
But they always think you have to do surgery to get rid of the cyst. But surgery for cysts, which is called ovarian diathermy, it's not removing the cyst.
No.
It's actually burning the inside of the ovaries,
Right.
which is called your ovarian stroma.
Right.
And that is what causes the hormonal imbalance.
Right.
So ovarian diathermy
Right.
is like your third line treatment for infertility to help the eggs to come out.
Okay, so that doesn't actually have anything to do with treating the cyst itself.
No,
Which
it's
is a
not
common
removed.
misconception
Correct, because
amongst the
people say they do the surgery
And the
to
cyst
remove
still-
the cyst,
yeah.
but it's not. You're
Right.
treating the internal parts of the ovary
Right,
to
there's a little
help.
bit of communication needed there, a little bit for
Yeah.
the patients, you know. So, Roshni, I'm going to move completely away from the topic of polycystic ovaries.
Okay.
And I want to touch on the topic of endometriosis. Now, endometriosis is probably a subject matter that that is poorly understood or poorly communicated to the population, and there may be a group of women out there who have suffered with this problem, and it might have been difficult for doctors to diagnose it. They might not have been known what was going on with them. So in the interest of these women and sort of to honor these women who have suffered this problem, let us put out information about endometriosis to the wider audience out there, to the greater population of women, so that they could recognize it in themselves if they do have it.
Okay.
What is endometriosis?
So endometriosis is when you have the lining of your womb in abnormal places.
Right.
So we have a little model that I could show you as well.
Yeah, go ahead. Literally. Right. So
So
that's your camera right there.
this is the lining of your womb, and which is called the endometrium. So this is what sheds every month with a period. So endometriosis is when this lining goes in abnormal places. So it's in the muscle, right? These little black areas. It goes outside. It goes behind. It goes into the vagina. It goes on your ovaries. It goes on your tubes. So it's the lining.
Josh, you can zoom in any more there? Right. So let's go ahead and show our audience at home the anatomy there now, please.
Okay, so this here is the womb.
Yeah.
This is an ovary, this is an ovary, this is your tube here, and another tube here. So all the little black spots
Yeah.
would be endometriosis, and they shouldn't be there.
Right.
They're only supposed to be in the lining and coming down this way
Right. So somehow the lining of the endometrium finds itself
into other areas.
into other areas where it should not be.
Correct.
And that is the diagnosis of endometriosis.
Endometriosis.
All right. So you could pull back there, Josh. So what symptoms would these patients have?
So most women who have endometriosis would have heavy, painful periods.
Right.
They have painful.
Most women.
Most women.
All right. I suppose the first question should be how common is this problem in women?
It's about 20% of women actually.
As well?
It's yeah.
So that's a lot.
It's underdiagnosed.
Exactly. Which was why I'm glad that you're talking about it.
Yeah.
So they would have painful periods.
Correct.
Is that the most common symptom?
Pain, yes, correct.
And how many women with endometriosis, you can leave that slide up there, Josh, with endometriosis will have painful periods? How many women of the category of people with endometriosis?
So probably about 15% of them.
15?
Yeah,
So,
because that's the most common symptom.
so you have about 85% of women without painful periods.
No, oh, sorry.
Am I getting it wrong there?
Okay, I said it wrong thing. Yeah.
So of the women who have endometriosis, how many of those will have painful
Yeah,
periods?
so the 85% will have the
Right,
painful periods.
so you'll have about 15% of women who do not
Don't.
have.
Correct.
And I suppose that might be the category of patients who might be more difficult
To diagnose. Yes.
All right, so you have a slide up there, which is symptoms of endometriosis. Can you go through that with our viewers, please?
Right, so if you think about endometriosis, this is the lining in abnormal places.
Exactly.
So when you are having a period, those little areas are bleeding as well. And
Right.
so therefore you could have, if you have endometriosis in your bladder, you could have painful urination. You
Wow.
can have endometriosis in your bowels, so you
Right.
get diarrhea and sometimes constipation.
Right.
And some women actually have difficulty going off during a period because
Right.
it's so painful to go off. The
Go back up the slide there, Josh.
the heavy period as well, because you have a greater surface area of bleeding, so you have the heavy period. We spoke about the painful intercourse because those little areas are in the vagina and in something called the uterosacral ligaments. And that is very painful with intercourse because if you touch those areas, you'd want to scream in pain.
Wow.
You can actually have bleeding in between periods.
Wow.
And the last thing, just like polycystic ovarian syndrome, you can actually have infertility. And the infertility is caused because when your tubes have the endometriosis, they become very sticky and you get what is called intratubal adhesion. So instead of your tube remaining open, they're stuck together and they could even be coiled. So that if you know the mechanism of conception, the egg and the sperm has to meet in the tube to get fertilized. It doesn't get fertilized in the womb.
All right.
So if your tubes are blocked,
All right. All right.
Difficulty
I just want
getting
to push you on a little bit quicker because Josh just told me that I need to push on a little bit more.
Okay.
What is the treatment? How do you diagnose this problem in women, and what is the treatment?
okay, so the diagnosis.
Well, let's do diagnosis first. We'll take a little break and then we'll come back to
Okay.
treatment. If you could tell us about the diagnosis.
So the diagnosis is mainly by ultrasound scan, right? If you can diagnose it, if you see a cyst or something called an endometrioma on your ovary
Okay, when you do ultrasound.
when you do an ultrasound.
So
So if you pull up
what-
slide 7.
No, that's practically again, right? You can leave up the slide there, Josh. Women come to the doctor when they're at home and they tell their mom or their granny, whatever, that's having painful periods and so on. At what stage does a patient or a young lady move from treating this at home into your office? I mean, sometimes you might think it's premenstrual cramps, sometimes you might think might just be taking Advil or whatever, or paracetamol. At what stage does a woman really need to come in and see you?
Okay,
What should
so-
alert them? When does granny need to say, no, this is not normal premenstrual cramps and this young lady needs to go in to see the gynecologist? At what
The
stage?
timing of
Yeah.
the pain, because
Yeah.
your pain usually will start from 2 weeks before a period.
Yeah.
Whereas period pain is usually with the period or a day or two before.
Right.
But endometriotic pain starts from 2 weeks before a period because it's hormonal.
Right.
So it's from ovulation.
Right.
So you start to get the pain and it gradually builds up until the period.
All right, so that's the important information for mommy and granny and
Yeah.
the patients to know that the timing of the pain is very important.
Yes.
It's before the actual premenstrual
Yes.
Pains, and that can kind of tune you into thinking about endometriosis. You could go ahead. You had a slide up there that you were talking about, and then we'll
And
take it.
slide 7 and 8.
Right.
8.
Right.
So doing a pelvic, so first of all, history.
Right.
Then your pelvic examination.
Right.
So you could, if you have endometriosis within the vagina, you
Yeah.
can feel that.
Right.
Then doing an ultrasound, you can also see it on an ovary.
Right. And then-
MRI, sometimes we don't use it that often,
And a
but the
laparoscopy.
gold standard is something called a laparoscopy,
Where you go in and
which
have a
is
look.
a keyhole surgery to look inside the tummy
All
and
right.
you see it.
All right. So, Roshni, we need to take a break. And when we come back, we'll go into a little bit more. So, guys, we're going to take a 1-minute break. And when we come back, we'll get straight into your questions. And then we'll discuss the treatment of endometriosis as well.
You're watching ACTN, The Voice. Connect with ACTN The Voice on Facebook or Instagram at ACTN The Voice.
ACTN The Voice, your family-friendly station.
Keep the popcorn popping, no, we're not stopping. Relax. So you know we in session. Time for talk through, adapt, miss a load. Relax. So you know we in session. Don't you delay, catch me on your TV. Every Thursday, ACT and The Voice in session. Yo, my name is Elisha. And my name is J Prince. This Thursday and every Thursday at 8 p.m. we are in session.
All right, guys, welcome back. Your Health, Your Choice here with Dr. Roshni Bissoondatt. I am Dr. Roopnarine, and we are talking about women's health. All right, Josh, I think you have some questions. Let's get straight into it. And then we'll get back to the treatment of endometriosis. Can drinking alcohol affect polycystic ovarian syndrome?
Well, if you consume large amounts of alcohol, remember alcohol has a lot of sugar.
Right.
So it's really the weight gain with alcohol,
Right.
not per se the alcohol itself causing the polycystic syndrome.
Right. Obviously, it's not drinking the alcohol will increase your sugars, increase your weight gain, would make all the symptoms worse.
Correct.
All right. So everything in moderation.
Yeah.
Everything in moderation, obviously. Josh, any other questions? Can someone with polycystic ovarian syndrome have a normal monthly period, Dr. Bissoondatt?
That is a very good question. And yes, they do, because we did some studies and it shows that 20% of women who have regular periods and do have polycystic ovarian syndrome.
Okay.
So in that category of women who have PCOS, they have regular periods, but they are not ovulating.
Okay.
So you still have to do ovulation tests. So although you think, oh yes, I'm having a period, I must be ovulating, it's actually been shown that 20% of women don't ovulate.
All right. Right, Josh, any other questions? Can polycystic ovarian syndrome cause liver issues later on? Are the two related? Is there any link? Maybe with the heavy drinking from the previous caller. Previous. Is there a link? I don't think there is.
So.
From my knowledge, I don't think there's a link with polycystic ovarian syndrome and liver disease.
And metformin, one of the long-term side effects of metformin is liver disease, but that is a rare complication.
I suppose, does polycystic ovarian syndrome predispose it to high cholesterol levels?
Yes.
Right,
yes.
So I suppose maybe with the metabolic effect of diabetes, hypercholesterolemia, you may get fatty liver.
Yeah.
But yeah.
Not the syndrome per se itself, the early stages anyway.
Exactly. So there may be some relation, in terms of metabolism, in terms of diabetes and high cholesterol, but in terms of the actual syndrome causing a syndrome with your liver and being a direct link, no, there isn't. All right, Josh, any other questions? All right, let's get a little echo there, Josh. Can pathogens cause the disease? Can pathogens, can any viruses, bugs?
No, this polycystic syndrome specifically to do with insulin resistance is a metabolic syndrome triggered by, again, genetics or an increase in your body fat.
Right.
Insulin, remember, some patients get viral pancreatitis. They're the ones who could actually get diabetes.
Yeah, they're still kind of rare.
But
yeah.
Not
So there's no real infectious nature to polycystic ovarian syndrome. Right, so Dr. Bissoondatt, if you could continue on with the treatments of endometriosis. You gave us the diagnostic part with the laparoscopy, sorry. Can you tell us about the treatments?
Okay, so if you bring up slide 9, so plain and simple pain relief, because like we said, the most common symptom is heavy, painful periods. So you can just use simple painkillers like your Panadol, your Midol, what we call the non-steroidal anti-inflammatory drugs, over-the-counter medications. Then the second line treatment would be hormonal treatments, and there are various categories. So there's from just the regular contraceptive pill, then you can move on, and that you can use it normally, so monthly.
Yeah.
You can do something called tricycline,
Yeah.
right? So we prescribe that specifically.
Right.
Then there are the progesterone-only methods, and there are different progesterone-only methods.
Yes.
So there's an injection, a 3-monthly injection.
Yeah.
There's a daily pill
Yeah.
as well, and then there's a coil.
What does the progesterone do?
What the progesterone does is it counteracts the estrogen, first of all, because
Right.
estrogen is what, if you want to say, feeds endometriosis.
Right.
Because that is how it lives. It
Yeah.
likes estrogen and
Yeah.
change in your monthly estrogen
Yeah.
levels.
Right.
So the progesterone counteracts this.
Right, so you reduce the,
So you reduce-
the growth, so to
Exactly.
speak. Yeah.
Also, a lot of these medications prevent ovulation. So in
Right.
so doing, you're not getting your estrogen levels.
Right.
So it's giving your body time to get rid of the endometriosis.
Right. What other?
Then you do have, one of the best methods is putting somebody into menopause. Because as we said, endometriosis is triggered by periods. It grows every time you have a period. So if you put somebody into menopause, there's no estrogen, there's no period, your body gets rid of the endometriosis.
Right.
But we don't usually do this. The usual time is 6 months, but you can extend it to 9 months. The main reason we don't go beyond that is because of the risk of osteoporosis. And remember, this is a syndrome of younger women. So you don't
Endometriosis.
want to get osteoporosis in your younger age.
Sorry, what is the age category for endometriosis? What's the most common age group?
The reproductive age group.
All right.
So teens to 50s, but you hardly see it over 40, although like a lot of times you do surgery for fibroids and you see endometriosis as well.
Okay.
So it's the reproductive age group.
All right, so teenagers.
Teenagers will get it, yes.
Okay. Okay.
And then there's surgery. So you can do laparoscopic surgery, or you can do open surgery where you literally burn away the endometriotic nodules. So it's burning, it's laser as well. Some professionals cut it away as well. So those are the treatments for it. And then if you're
Is surgery successful?
Yeah,
Does it
is.
come back?
It can.
What's the risk of recurrence? And Trinidad, when we say successful, we're talking about we want it bloody back. What is the risk of recurrence?
So it depends on the mechanism of the endometriosis, which we really didn't speak about. So there are 4 theories for endometriosis. The most common one is
Right.
called retrograde menstruation, which is when instead of the period coming forward down through the vagina, it goes back through your tubes and into your tummy. That's
Right.
one. Your second method is through the blood system,
Yes.
through your veins,
Right.
arteries and veins. Then there's the lymphatic system, and then there's it just pops up. So it's
Right.
not through your blood system. They call it in situ development.
Right.
So if the theory of retrograde menstruation,
Yeah.
it happens every month. So
Right.
you could do surgery to get rid of it. Comes
It could
right
come
back
back.
the month out.
Come
And
back.
I've had patients like that
Right.
who had surgery and then they came with pain the month after.
So
And
I
it's like,
suppose the
yeah.
treatment may be a combination of things then.
So if you do surgery, you need to do follow-up medical treatment
Right. Because
to
they don't
prevent
want
it from coming
going
back. Yes, and then regular checkups to make sure, like years later, it doesn't come back.
Right. Right. And what are the treatments you have for it?
Well, for infertility, it's more difficult because if you have
Does it predispose women to infertility?
right, because of the scarring of the tubes.
Right.
So, and if your tubes are blocked, you depending on where the blockage is, you really can't unblock tubes. Sometimes, if you have a little, like a plug, a mucus plug, there are procedures to remove that mucus plug. And some patients we do something called an HSG, which is a X-ray where you flush dye through. So that's not really for true endometriosis. That's if you have like a little minor plug there.
All right.
And sometimes you actually have to, if you have swelling of your tubes, you have to remove your tubes.
All right.
Not to then to move on to in vitro fertilization to get pregnant.
All right. So, Doc, we have 2 questions coming in. So, Josh, if you can give me a little bit of feedback on time. Okay. Can endometriosis and fibroids be painful together?
Yes, and they could coexist. You can have fibroids and endometriosis, and they both cause heavy painful periods.
Right.
Both of
So,
them
I
together.
mean, yeah, that's the thing. Yeah? I mean, sometimes in medicine, you look at one, you think that has to be one diagnosis alone.
Exactly.
And generally it is, but sometimes you meet conditions where there's more than one thing in there causing your problem.
Many times you do a hysterectomy for fibroids.
You see endometriosis.
And you see endometriosis as well.
Yeah. And maybe it was the
Many times.
endometriosis causing the
Cause
problem.
the pain.
Yeah.
Because the endometriosis
Difficult
could cause
diagnosis.
adhesions as well inside your tummy.
Yeah.
Where things get stuck
I mean,
together.
look at the quantity of different symptoms as well. Pain on urination, pain in going to the toilet. Pain, you know what I mean? It's so many different possibilities.
You can get endometriosis in your lungs.
You can get it with your lungs, yeah.
Yeah.
And I've heard about it before.
Yeah.
You have a second question there, Josh. Could you put it up, please? What is it about East Indian people causes them to be genetically predisposed to polycystic ovarian syndrome? So you said there's a genetic predisposition. What is it about the race?
It's the diabetes. So
Right.
diabetes is a genetic syndrome.
Right,
So we have that predisposition.
right.
So it's just East Indians and Africans. So Caucasians don't have as much of that genetics for diabetes.
You mean the
They
insulin
can-
resistance?
Yes.
The
yes.
insulin resistance more than the diabetes?
Yeah.
Right. Well, I suppose, yeah, and centripetal obesity, the metabolic syndrome, predisposition,
Yeah.
that all comes with in the East Indian race. And I suppose that's what gives you the insulin resistance and the risk of increased polycystic ovarian syndrome.
Yeah,
or the
it
presence
is to do with the
polycystic ovaries.
diabetes. When you speak to most people who have the polycystic syndrome,
Probably cultural diet as well.
well, it's triggered by it.
Yeah,
But you
exactly.
have that predisposition for the diabetes already.
Yeah.
But the
Single
diet
trigger
and the
already.
lack of exercise is what
Yeah.
will trigger the polycystic syndrome.
Yeah.
It will trigger the diabetes later on in life
Yeah.
as well.
Yeah. Diabetes is a real it's a real emergency health problem in the Caribbean.
Caribbean, yes.
In the Caribbean especially. And Northern Latin America, diabetes is an emergency of a health problem. Right. So the what other treatments we have? That was the final
That
question.
was, yes.
Right. So we have no other treatments for endometriosis. There's the combination treatment towards the end.
Correct.
All right.
Medical and surgical.
So I'm really going to throw in a spot there and try to get in a little bit of discussion about infertility. Right, because it's a bit combination of these two topics. A young lady comes to your office and she's having difficulty getting pregnant. What should they do? Or at home and they're having difficulty getting pregnant. What should they do? What should the couple do? What investigations need to be done for these people?
Okay,
Or
so
what can they do initially at home to help themselves before they
so
come?
that's a good question because
Yeah.
a lot of
Bear in mind we have
patients-
about 8 minutes left.
Okay. A lot of couples don't realize that there's a short time, a short window to get pregnant every
Right.
month because your egg only survives 24 hours.
Right.
And the majority of sperm survive 24 hours and the rest survive 48, 72. So
Right.
there's really like about a 3 to 5 day window to get pregnant any 1 month.
Right.
And it's when your egg comes out. So a lot of couples think at any time you have intercourse,
Yeah.
you can get pregnant.
And that's not the case.
That's not the case because again, it's a specific time, which is 2 weeks before a period.
Right.
So the first thing is timing it properly.
Right.
Having intercourse during that fertile week.
How would a woman know that it's the how would you know it's a fertile week?
So you could go based on an app,
Right.
right? So knowing that if you have a regular period,
Yeah.
you ovulate 14 days before a period comes down. So you
Right.
could count it and know.
Exactly.
You can also check the cervical mucus.
Right.
So some women are very in tune with their bodies and the changes in their vaginal discharge.
Right.
So it becomes kind of egg white
Right.
and very stringy. So if you check your discharge and you do this,
And
you'll see
stringy.
strings.
That's
And that is ovulation.
right. And that's your fertile period.
That's your fertile period.
Right.
So you can't have intercourse one day. It has to be a few days.
Right.
So we always tell couples have intercourse a few days before and a few days after expected ovulation in
Right.
case an egg comes out early or it comes out late.
Right.
So we normally say day 10 to 18 to
Right.
get pregnant.
Right.
Every day during that week or every other day. Don't miss more than one day in between.
Okay.
And then the other issues would be blocked tubes. So we have to do the investigations of this thing called the hysterosalpingogram, where you inject dye and check to see if your tubes are open. And you have to check the sperm as well, because we did studies in Trinidad with the Trinidad IVF team.
Yes.
And it has actually been shown that 50% of infertility in Trinidad is caused by the male. So you have to check the sperm count as well.
Right. People naturally assume
It's the woman.
it's the one, but
Correct.
it takes two hands to
takes
clap when you're making a baby, isn't it?
So you do a sperm test, you do the tube test, and you check.
You have a
to
lot of
see-
male infertility as well?
Yeah.
Okay.
It is 50% of
50%.
of infertile couples. It's due to the male.
Right. Right. So yeah, the man does a sperm test as well.
Yes.
Let's say all that is fine. Man's sperm is fine. The woman's
Tubes are open.
tubes are fine. Ovaries are fine. What other advice would you give them in terms of? I mean, it's not going to happen right away. Sometimes you have to
No,
wait. Some people.
exactly. So 60% of couples get pregnant by 1 year.
Okay, so it doesn't happen in the first
No,
month
it
or the
takes a
first-
while,
takes
and
a while.
another 20% in the second year. So 80% of couples who have absolutely no problems
Yes.
could take 2 years to get pregnant.
So it's not that easy, is it?
No, it's not the first time that you do it that you will
Right.
get pregnant.
Right.
Yeah, so
All right. Yeah, Josh. We have about 3 minutes left in the program, but we'll still take the last question and then we'll wrap up after that.
Okay.
All right, Josh, you put it up. What is the best thing to do with endometriosis and fibroids together? I assume this is a follow-up question to the condition of endometriosis and fibroids.
okay, so
What is the solution to treat those two conditions in one go, if you could?
so it depends on how early of the both.
Yeah.
Because if you pick it up very early, in my opinion,
Yeah.
if you're not looking
up
to
which
get
one?
both,
Right,
if you
right.
pick up fibroids early,
Right.
small fibroids
Yeah.
and endometriosis,
Yeah.
I would recommend something called the Mirena coil
Right.
because it will treat both. It prevents the fibroids from getting bigger.
Right.
It will treat the endometriosis as well.
Exactly.
And beyond a certain point where, let's just say 5 centimeters of a fibroid,
Mm-hmm.
you're more looking at surgery.
Right. And invasive surgery, or
So, yeah, surgery to remove the fibroid.
you do it laparoscopically?
It can be done laparoscopically.
And I
or
suppose
open
at that point
surgery.
in time, once you go in laparoscopically, you could fix
You
the
fix the endometriosis
as well.
But the key is pick it up early so you don't have to reach the point of surgery.
Exactly.
You could do medical treatments.
Right.
The other one that I spoke about, the GnRH analogs, which is putting you in a menopause,
Yeah.
that would only work for fibroids for 6 months.
Right.
But it will regrow after. So it might get rid of endometriosis, but your fibroids will regrow.
Okay.
So the Mirena is probably one of the best options.
All right, I think you answered that question. All right, Roshni, so we've come to the end of the program. It was good. It flew by very quickly. It gave us a lot of important information. If people listen really carefully, it gave us a lot of explanations to a lot of things that we take for granted. And I'd like to thank you for that. So yeah, we would probably try and do a program on fibroids, probably a little bit more infertility in the future, and also probably touch on cervical cancer in the future. So thanks for coming on tonight.
You're welcome.
All right.
Okay.
All right, guys, so thanks for tuning in. Thank you very much, Dr. Roshni Bissoondatt, for an excellent presentation tonight. Thank you at home for looking on. Thank you as well for sending in those messages and those questions. And we'll see you all again next week. All right, guys, so have a pleasant evening. God bless. Take care. We'll see you again next week. Good night, everyone.